Thank you. So the next case, I was tasked by Professor Shahab to go over right ventricular shock with, in the setting of an acute myocardial infarction. This is a brief case of a 56-year-old woman, 56-year-old gentleman with known CAD and prior PCI of LAD, presented to hospital for chest pain for several hours, developed progressive hypotension by the time getting to the cath lab, and you see the ECG showing significant ST elevation in inferior lead with ST depression in the anterior leads. These are representative of his left system coronary angiogram with at least moderate to severe restenosis of the prior LAD stent. As you see, given the protocols that we have currently in place, this is not the case from here because we do not have an RV Impella here yet. So PCI of the right coronary artery, but prior to that, placement of Impella CP. This is before and after pictures of the PCI. We've referred to the different protocols. What we use is the National Cardiogenic Shock Protocol of presentation with cardiogenic shock, putting the Impella CP, doing the PCI, and after PCI, doing the right heart catheterization. And depending on your CPO, if your CPO is less than 0.6, then you need additional support. And calculating the PAPI will allow you to decide whether you need left or right ventricular support. If your PAPI is less than 0.9, then you need right ventricular possible right ventricular failure, then need RV support. And of course, if your PAPI is good, but your CPO is less than 0.6, then you need more left ventricular support. In this particular patient, these are the hemodynamics. And as you can see, both CPO are significantly compromised, and also the pulmonary artery pulsatile, the index of 0.5. So this patient had placement of RP Impella, given the hemodynamics that you can see. These are the hemodynamic on day 2. Lactate has improved, and the PAPI is better, not to the point of being able to explant, but definitely both CPO and PAPI have improved. This is on day 3 hemodynamics, with your CPO now being 1.1 and the PAPI being 2.3, as well as normalization of your lactate and pH. This is which did not show you. This patient went back to the cath lab and explanting both on day 4. This is day 3, I'm sorry. This is post-procedure echo right after the acute event, and this is the echo on day 3. Obviously, this has been mentioned. Anytime patient presents with cardiogenic shock, we need to decide whether it's predominant LV failure, RV failure, or concomitant respiratory failure, and decide on the mechanical circulatory support based on the patient provided. In acute setting, the right ventricular support devices, I think is being reviewed. In case of right ventricular support, you can either have Impella, Protec Duo, or ECMO. And in acute setting, RV dysfunction can be suggested either by elevated CVP, CVP to wedge ratio, PAPI, and RV stroke index. And depending on those, you may require mechanical support, as in this case. And of course, coming from Detroit, where National Cardiogenic Shock Initiative, I think the comment that I wanted to make, we're all saying that we need more data and more randomized trial. And it is very true. I think in certain setting, doing a randomized clinical trial, doing a CPR, it would be tough to get a consent from someone who is doing a CPR to randomize them to what. And there are a number of areas now that the nested registries are used to provide adjusted data to guide management. So cardiogenic shock may be one area that it would be difficult to generate randomized clinical trial. And of course, we know all the barriers that may prevent us from doing that. So registries may be a very good way of producing data which can guide treatment strategies. Dr. Fabrizio already mentioned the RECOVER-4 trial that is currently evaluating the Impella CP in patients with cardiogenic shock. I would be remiss if I don't mention the local support by Emirate Cardiac Society, Professor Shahab, and the leadership team, as well as the committee, including Dr. Fabrizio. This is the first meeting that we had a few months ago, and hopefully with local initiative and industry support, we get where we need to be in the near future. Thank you.